Welcome all, my name's Henry and this is my video on esophageal varices. Alrighty, let's start by saying what is an esophageal varice? Well, it's a dilated submucosal distal esophageal vein. And if we look at the photo here, I'll just circle it. It's pretty clear to see, you can see the dilated vein there. So that is an esophageal varice right there. And these veins connect the portal and systemic circulations. So let's go into a bit more depth as to why this occurs. Alrighty, so esophageal varices will occur due to portal hypertension. Now normally the portal vein, as depicted in this image here, will carry nutrients and deoxygenated blood from the GI tract, pancreas and gallbladder to the liver. However, if portal hypertension is occurring, then blood cannot flow through the liver. If it cannot flow through the liver, then the portal pressure rises and the blood will divert through collateral vessels. These collaterals relieve some of the pressure but will become dilated and fragile, which is why varices form and may rupture. Portal hypertension is anything above a pressure gradient of 5 millimeters of mercury or more. However, 10 is when it is considered clinically significant. Alrighty, let's go through the causes of portal hypertension. So let's start with prehepatic causes. These occur before the blood reaches the liver. A common example is portal vein thrombosis, where a clot obstructs the portal vein. Now, intrahepatic causes. So sinusoids are specialized liver vessels that allow the blood to flow slowly through the liver for nutrients exchange, deoxification, and interaction with liver cells. So because these are the most common causes, they can be subdivided into 3 different categories. So pre-sinusoidal is conditions such as primary biliary disorders that narrow the small vessels before blood reaches the sinusoids. Then there's sinusoidal, which is the most common, and it is due to cirrhosis, where fibrosis and architectural distortion impede blood flow at the sinusoidal level. So chronic hepatitis and alcohol-related liver disease are important contributors to this. So this is really important when we are considering our history taking. And then post-sinusoidal are disorders such as veno-occlusive disease, where the small venules draining the sinusoids are blocked. And then the final category is post-hepatic causes. These occur after the blood leaves the liver. An example of this is hepatic vein thrombosis, right-sided heart failure, and constrictive pericarditis, all of which impede hepatic venous outflow. Alrighty, so portal hypertension will cause some blood flow changes. So collateral vessels will develop as a natural bypass when portal pressure rises. These portosystemic connections divert blood from the high pressure portal system into the lower pressure systemic veins. While they help relieve pressure, they become dilated and fragile, increasing the risk of esophageal varices, and then will rupture, causing potentially life-threatening bleeding. Alrighty, so as mentioned earlier, the portosystemic collaterals will divert blood from the high-pressure portal system into the lower-pressure systemic veins, including the inferior and superior vena cava, helping decompress the portal system. Now, another major site for collateral formation is the gastroesophageal junction. So here the blood from the portal tributaries, specifically the left gastric vein and the short gastric vein, is then redirected into the azygous vein, which then drains into the superior vena cava. This diversion reduces the portal pressure, but also creates veins under high stress. So the increased blood flow and pressure in these collateral veins cause them to become dilated, tortuous, and thin-walled, especially in the submucosal veins of the distal esophagus. These structural changes can lead to the development of esophageal varices. Alrighty, so let's go over some key signs and symptoms of esophageal varices before it ruptures. So let's start with the main one, chronic liver disease, and in particular cirrhosis, which is a result from prolonged alcohol use leading to structural changes in the liver that impede blood flow. So recognizing a patient's history of alcohol consumption is really important here. Let's move on to the next one, which is ascites. So accumulation of fluid in the peritoneal cavity due to increased hydrostatic pressure from portal hypertension and decreased oncotic pressure from low albumin levels. So To identify this, you need to inspect and palpate the patient's abdomen. All right, so moving on. So let's go jaundice. So that is the yellowing of the skin and eyes from impaired bilirubin metabolism in the liver due to chronic liver disease. So again, this will be able to be identified from inspection of the patient and looking into its skin and the eyes. So caput medusae. So this is a network of enlarged superficial veins radiating from the navel on the abdomen caused by collateral circulation between the portal and systemic venous system. So again, you'll be able to identify this from both palpation and inspection of the abdomen. Should be quite obvious. All right, so let's move on to pruritus. So this is the generalized itching caused by accumulation of bile salts in the skin due to impaired liver excretion. So this should be able to be identified with some rashes on the skin, or if they state that they're feeling a bit itchy, this is what this is. So moving on to one of the last ones, which is weight loss and muscle wasting. And this is due to the malnutrition and protein loss due to chronic liver dysfunction. So this you'll probably get from history taking and potentially asking family members if they've lost a lot of weight recently. And now I'm just going to have a quick trigger warning because the next two slides will have some images of blood. Alrighty, let's go over the rupturing of an esophageal varice. So if we look at the image here, we can clearly see the rupture site with the blood spurting out. And the rupture of a varice can cause sudden and severe blood loss, leading to hypovolemic shock, which leads to low blood pressure, tachycardia, and organ hypoperfusion. Therefore, there is a high mortality risk that comes with the rupturing of an esophageal varice. And without urgent medical intervention, the bleeding can become life-threatening. So the typical rupture site most often occurs at the gastroesophageal junction, where the portal systemic collaterals form. Alright, let's go over some reasons for variceal ruptures, starting with portal hypertension severity. If the portal venous pressure gradient is above 10 millimeters of mercury, then this will strongly increase the risk of a rupture. Infections can acutely increase portal pressures along with alcohol intake, which causes mucosal irritation and sudden rises in portal pressure. Let's move on to the size of a varice. So the larger and more dilated varices are, then it will be a lot more likely to rupture and then bleed. Also, the thinning of overlying mucosa from erosion and ulceration caused by acid reflux and local trauma, such as food boluses, will expose vessels, making them thinner and easier to rupture. Finally, hepatic dysfunction. So the decreased clotting abilities from cirrhosis will make the bleeding a lot more severe if it does rupture. Alright, let's go over the key signs and symptoms of a rupture, starting with hematemesis, which is the vomiting of blood. This occurs because of the ruptured esophageal varices releasing blood directly into the esophagus and stomach, which is then vomited. Let's move on to melena, which is a dark and bloody stool. This develops because the blood from the upper GI tract is digested, turning the stools black and tarry. Hematochezia, which is the fresh red blood per the rectum. When a massive upper GI bleed occurs, the blood passes rapidly through the intestines, resulting in fresh red blood per the rectum. And finally, hypovolemic shock. So rapid blood loss reduces circulating blood volume, causing hypotension, tachycardia, cold and clammy skin, and decreased perfusion to organs, which can lower the GCS. Alright, let's go over the management of a rupture in the paramedic setting, starting with the awareness of the lethal triad. Patients may develop coagulopathy, hypothermia, and acidosis, each of which worsens bleeding. So recognition of this triad is critical in early management of the patient. Therefore, let's start with thermoregulation. So to keep the patient warm, using blankets or a heated environment, such as the ambulance, is really important to prevent hypothermia, because hypothermia does impair coagulation. Let's move on to fluid resus. So it's really important that we gain IV access and administer some fluids. So to start with, it's really important that we only administer the minimum amount of crystalloid fluid needed to maintain alertness or a palpable radial pulse. Excessive fluids may worsen coagulopathy and bleeding. Alright, Moving on to tranexamic acid. So TXA is an antifibrinolytic agent that prevents clot breakdown, therefore help cease the bleeding. Early administration, so within 3 hours of the bleeding onset, will reduce mortality but should not delay the rapid transport. Alright, so let's go on to movement minimizations. So let's avoid excessive patient movement during extrication and transport to prevent the disruption of the clots. And finally, rapid transport and notification. It's really important to prioritize immediate transport to a facility. Thanks for watching, and I really hope this has helped you better understand esophageal varices with their key signs and symptoms and the importance of rapid recognition and management. Thanks.